Good evening, one and all. Myself, Dr. Rajul Jain, consultant endocrinologist at Medanta. On behalf of entire Medanta endocrinology fraternity, I welcome all the esteemed guests to this academic get-together. The theme for today's discussion is something very novel. It is inpatient hyperglycemia. So we all discussed various treatment algorithms, various diagnostics of management of hyperglycemia on outpatient basis. But somehow amidst all this, inpatient hyperglycemia takes a back seat. So the prevalence of inpatient hyperglycemia is huge. Uh, Almost every third patient who is admitted may require management of hyperglycemia. So it basically requires a protocol-driven approach. The population is also very heterogeneous. We have to cater to critically ill patients, non-critically ill patients who are admitted for daycare procedures and so forth. So at Medanta, we have a humongous task of managing hyperglycemia of around 100 to 150 patients daily. So it is all a teamwork. The team comprises of consultants, diabetes educators, endocrinology residents, and various other paramedical staff. So we have well-defined insulin infusion protocols in place. Those protocols are well validated. The follow-up of patients is great. So in the past few years, many new concepts have emerged regarding inpatient hyperglycemia. Uh, we have revised glycemic targets. The insulin protocols have changed. The use of technology has emerged, and so forth. So discuss all these things in detail. We have a team of very eminent endocrinologists who will share their rich wealth of experience with us all. So I hope this would be an enjoyable and a fruitful discussion. So I welcome once again all of you. So to set the ball rolling, we have our first speaker, Dr. Sunil Kumar Mishra, sir. Sir is a senior director and head division of endocrinology and diabetology at Medanta. So, sir would guide us about inpatient hyperglycemia, its relevance, approach to treatment, and long-term follow-up. Over to sir.
So, thank you, Dr. Rujul, for kind introduction. Slides not coming. Slides. So, again, as told by Dr. Rujul, the management of the in-hospital hyperglycemia is both art and science, and especially when you have a large hospital setting where various different type of patients are admitted. So, goals differ, patients' movement differs, and it's a huge chance for anyone to take care of good glycemic control, and also get a good OPD follow-up. So as you all know that diabetes control is pathetic in outpatient setting, and so when a person is admitted in, excuse me, so when a person is admitted in a hospital, we expect that the glycemic control is not going to go good. So that gives another challenge for the management of the diabetes. So my all colleagues will help you in understanding the glycemic control in a hospital setting. So hyperglycemia is a common comorbidity in medical and surgical in a community hospital, but when it comes to our hospital, in our CABG and PTCA ward, approximately 40 to 50% of the people are having hyperglycemia that includes both diabetes and new onset hyperglycemia. So if you see in this particular slide, so sorry. So normoglycemia in 62%, this survey by Umperejanot et al. And if you look at 26% were non-diabetic and 12% were new onset hyperglycemia. This situation varies from the type of the hospital you are working in. In our hospital, as I told you, around 40 to 50% of the people are coming with the hyperglycemia and diabetes. So regarding the what is the evidence for the inpatient control of diabetes, so look at this slide how the mortality changes. So hyperglycemia and mortality in medical intensive care unit, as the glucose level start increasing above 100 up to 199, there is a two-fold increase in the mortality. Further increase up to 300 by threefold, and more than 300 it increases by fourfold. So increasing hyperglycemia, increasing mortality. Similarly, if you look at here, so a newly diagnosed diabetes as well will have a high chance of having the mortality in inpatient care, because you are not aware about the hyperglycemia of that particular patients, and compare with the patient with the normal glucose level, patient with diabetes will have excess mortality. So what are the mechanism for adverse effect of hyperglycemia in acute illness? So this just pathophysiology based science, what is the reason for that? So illness lead to stress hyperglycemia. So stress will increase the stress response of the cortisol, epinephrine, and of course these hormone will further impair the glucose utilization at the level of the liver and also at the level of the muscle. So there will be excess glucose, and the lipolysis will increase in the free fatty acid production. These level fatty acid, high fatty acid and high glucose level and illness will increase the risk of the hemodynamic insult, increase electrolytes losses, oxidative stress, myocardial injury, hypercoagulability, and altered immunity, all resulting into the decrease in wound healing, increased inflammation, and endothelial dysfunction. And this becomes a vicious cycle of illness and increased glucose in inpatient care setting. And you get a very limited chance to intervene here and to break this vicious cycle of the stress, hyperglycemia, and high glucose level, resulting into this kind of the damage. So outcome, now looking at what is the outcome of inpatient hyperglycemia resulting into the better outcome, like clinical outcome. So studies after 2000 have shown that like if you are targeting for good glycemic control, early intervention trial, so decrease infection, mortality at 1 year, and even the survival up to 2 years. So these are the studies which showed that, which gives an encouraging result in different kind of the patient population, like CABG, the mixed patient, and the and non-cardiac patient, that the mortality does decrease with early intervention. Now this slide shows you the better outcome results. So intensive insulin therapy in critically ill patient in ICU have shown either non-significant result, but if you see in the RABBIT-2 trial by Umpirej in surgical ICU, it has shown a significant difference in terms of the outcome. But only thing is that in the NICE sugar study showed an increase in mortality if you are aiming for too tight glycemic control. So I would like to just briefly tell about here the NICE sugar study. In NICE sugar study, the intensive harm actually aimed at a glucose level of around below 100, and they were able to achieve around 118, and the conventional arm were able to achieve 145. Therefore, there is 90-day mortality. The p-value is becoming significant here, so 90-day mortality were higher in a patient with the tight glycemic control. So this approach suggests that probably a midway approach is better. So I will just share you about the target. So what is the takeaway from these trials? That good glycemic control is required. There is excess mortality. As opposed to the near normal control, it should not be approached for. Hyperglycemia and hypoglycemia are both marker of the poor outcome. So both ends are bad in critically and non-critically ill patients. My colleague will discuss about that. And recent study shows that the fair control, apart from the laissez-faire attitude towards the inpatient, should be avoided. So current recommendations suggest that, I think probably this is better to remember, the recommended target in the most of the patient is between 140 to 180. Above 180 you have to intervene, should not be aimed for, and acceptable is between 110 to 140 in some subsets of the patient. Below 110 is again not recommended. And similar is from the different ACE and ADA recommendation in non-ICU setting. Pre-meal target is below 140 and random glucose and bedtime glucose below 180s, and avoid hypoglycemia. You need to reassess if the glucose level is falling below 100. Hypoglycemia is defined in a hospital care setting below 70, and severe hypoglycemia, because patient will not come ask for third party assistance, below 40 is the severe hypoglycemia. So these recommendations are again validated in the recent publication either in Diabetes Care. This is the latest edition, Diabetes Care in the Hospital, Standard of Medical Care in Diabetes Care 2022, and also from the Endocrine Society, the management of the hyperglycemia in hospitalized adult patient with a non-critical care setting. Now, I will take you something different. The strategies for the effective discharge, you have managed well. My colleague will talk about the management. So how we should discharge the patient, because in 4 or 5 days or even 7 days, you have to plan everything, and you have to discharge patient, and you have to patient should follow you in OPD care as well. So there is a relationship between the inpatient and outpatient diabetes management. Outpatient depends upon the compliance, and glycemic goal depends upon the patient. In-hospital management is entirely our responsibility. So compliance and glycemic goal depends upon physician, nursing, and hospital staff. So if we have a better system here, so we will probably able to give a good glycemic control and avoid to reach those targets. So discharge planning should start from the beginning. So why there is a problem? So pressure of the discharge patient early. When the patient's procedure is done or patient becomes all right for the current problem for which patient is admitted. So there is a pressure for discharge. Billing in especially in the private hospital has to be minimized. Shorter hospital stay. Competing priorities are there. Lack of the primary care physician, nursing workload, lack of the diabetes specialist educator, and the weekend discharge. So all these factors results into the discharge without any diabetes advice, and that often happens. Many times we get a call, our patient being discharged, we were diabetic, we were given insulin in the hospital, and we don't have any discharge advice. So this needs to be coordinated as soon as the patient is admitted. So create a collaborative team, identify patients with hyperglycemia and diabetes, develop an individualized team plan for each patient, and determine the transition of the discharge strategy and monitor the progress. So we have a team. Whenever a patient gets admitted, the patient is seen by our team. We have consultant and our DNB fellows in endocrinology who are following. They follow the patient 24/7, and our diabetes educators start meeting patient from the beginning, and they go with the discharge with the diabetes education regarding the diet, insulin, and our coordinator then follow the patient in OPD basis. So this is how a teamwork helps, and it becomes very simple for us, but it took around first 3-4 years to reach to this level of the smooth the IPD care. So transition from the from hospital to outpatient care, preparation for transition to outpatient setting should begin at the time of the hospital admission, and it is a multidisciplinary team. So one person cannot help you. Bedside nurse, a team of doctor, which of course consultant is there, and then the junior doctor, resident doctor, DNB fellows, registered dietitian and educator is there, and finally your coordinator who is following patient in OPD. So there should be clear communication regarding that. Outpatient provide care in the critical care, ensuring the successful transition to outpatient management. And this is how, because as I told you, 70 to 80% will have poor glycemic control, and this gives you a good opportunity to give good glycemic control for patient benefit as well as for your OPD, bringing your OPD numbers and maintaining a good OPD follow-up, and patient will definitely follow you in long term. So pre-discharge checklist should be there, diet information, monitoring and strip. Patient should be able to take care of the glucometer, how to monitor the glucose, prescription for supplies of the medication including needles. So in our hospital we give demo in each floor and how to take insulin, and at least once or twice patient or caregiver do help them in getting the insulin dose done over their self. Treatment goals are defined. My colleague will help you in understanding that. Contact number for OPD follow-up should be given, and sick days in hypoglycemia training and skill is taught to the patient. So discharge planning depend upon the etiology of the hyperglycemia. You may have a patient with the stress hyperglycemia that resolved in the hospital, and you have to just tell patient to get some glucose level, a glucose level and HbA1c after some time. Previously undiagnosed diabetes, plan to confirm the diagnosis and implement therapy and education as per the need. And previously diagnosed patient is the largest chunk, and as I told you, most of these patients are poorly controlled, and this gives you a good window of opportunity to intervene and help them in getting good glycemic control and understand the diabetes so that minimize the complication in other organs as well. And outpatient follow-up can be done. So HbA1c does help you in giving a good idea about the post-discharge treatment. So always HbA1c should be done whenever your patient is admitted in hospital. Glucose and HbA1c are two important things. Glucose is like a vital for any individual whosoever comes to the hospital, and once the glucose level is high, so you should definitely get HbA1c, and we will discuss that in further discussion. So HbA1c more than 6.5%, that is inpatient diabetes, refer to diabetes education and self-management to be talked. If it is below between 5.5 or 5.7 to 6.4, so these are the people with the stress hyperglycemia. Their diet, exercise and weight, everything should be discussed. Probably they may not require anti-diabetic therapy, if at all will be for a brief period. Now here comes the, depending upon the glucose level between 6.5 to 7.5, you may have to change the plan. You may add a third agent, non-insulin agent. You may discuss about the basal insulin. Further comes between 7.6 to 9%. Already in two non-insulin agents, at least add a basal insulin at bedtime here. More than 9%, discharge should be done on the basal bolus, and especially if the patient is already undergone a major surgery, should be discharged on the basal bolus. Never immediately put patient on the oral agent and basal insulin, because many times the glucose control worsen. Over the time, if you have an opportunity to add any oral anti-diabetic drug like SGLT2 inhibitor, GLP analog, or the DP4 inhibitor, that will definitely help a patient in decreasing the glucose level. Then you can discuss about the convenient insulin approach, twice daily premix co-formulation and less complex insulin regime. But these are the people who would require insulin definitely in long term. So in summary, patient need for diabetes education has to be assessed preferably upon the admission, and glucose control, glycemic targets, and their compliance should be addressed at that point of the time. And most importantly, they should be educated about the importance of the good glycemic control in long run. So many times they understand it easily, especially if they have a directly diabetes related complication like retinopathy, nephropathy or cardiovascular disease. But other time, if they are admitted with a different purpose, probably they may not give a good weightage towards the glycemic control. So it's our responsibility, because they are with us for next 5-7 days. During that 5-7 days, whatever the best we have to give them in teaching. Patient has received the necessary skill and training. So education is the most important here. Provider post-discharge plan for diabetes and follow-up plan should be given them. Patient has received clear instruction about the medication, name, doses, when to take, and many times you will get a call that I have taken the bolus insulin instead of the basal insulin, and the dose reverses other way around. Patient have a scheduled follow-up appointment at the time of the discharge. So in our from our discharge advice, we write after 3 days at least they will communicate with us through telemedicine, and later on when they are coming for scheduled hospital visit, they will see us in person. So written documentation of the point of care will be completed at the time of the discharge. So thank you very much for your kind attention. I have finished a minute prior to my scheduled time. Over to Dr. Ruzul.
Thank you, sir, for such a lucid presentation, giving us an overview of inpatient hyperglycemia. We will take all the queries at the end of 3 sessions in the panel discussion. So the next lecture, an important subset of inpatients is patients who are critically ill. So for a practical approach to management of hyperglycemia in critically ill patients, we have Dr. Jasjeet Singh Vasir with us. Sir is Director Division of Endocrinology at Medanta. So over to sir.
Thank you, Rujul, and thanks for accommodating my request for preponing my lecture. So whenever I would come, projection नहीं हो रहा है? हाँ. So whenever I would be listening to a talk on inpatient hyperglycemia and it would come to critical illness, it used to get very boring. Lot of numbers, lot of changes in doses, and I thank Dr. Sunil for this slide set he had provided. It's extremely simple, gives you the basic concept about what to do and how to do. And when it comes to doing it, we all are there since we have developed these protocols for our institution to help you out, guide you and support you in instituting these protocols in the hospital. So we've understood that hyperglycemia, diabetes, stress hyperglycemia or newly diagnosed diabetes is extremely common in the inpatient setting, and it has a direct impact on outcomes, which is morbidity and mortality. And the third part is optimal glycemic control. I use the word optimal, not strict. Optimal glycemic control, as we heard in the last discussion, 140 to 180 has a definite impact in most of the patients, not all, and we individualize the targets for our patients. So that's the preamble for the entire discussions on inpatient hyperglycemia management. So let's go on in understanding in the really critically ill patients in the ICU, what do we do and how to do them. So I'll be briefly talking about the guidelines, the targets of blood glucose levels, which have already been covered, talk about protocols for insulin infusion, glucose monitoring, and a very important part where a lot of errors happen is transiting from the ICU to the ward, from the NPO to the normal diet. That's where a lot of problems happen. So that's an area of stress in our mind when the patient is transiting. We'll talk briefly about that also. So in this case, we have a young gentleman. Dr. Sunil talked about individualizing the therapy. Like we do in the outpatient, the same or similar principles apply to the patients we see in the hospital also, in the ICU also. A young patient, expected longevity with an illness like pancreatitis, yes, is a severe illness, but the chances of full recovery and a happy discharge are very high. So what do we think here? As a clinician, what are we thinking? Yes, we need to give this patient the best kind of care, including the management of pancreatitis and glycemic control. There's no question about the fact any hyperglycemia, an inpatient hyperglycemia requiring treatment, the cutoff point is 180. Consistently above 180 requires treatment, and the treatment is insulin. For those in the critical care setting like the ICU who are not eating, the route of delivery has to be intravenous insulin, nothing else. Targets we've understood. We'll talk more about the insulin infusion, hypoglycemia. So therapy here is a balance, it's a skill, is let the sugar readings be in 140 to 180. And the very important thing which has a direct impact on outcomes and direct mortality is hypoglycemia. So you need to balance out your approach, your aggression to maintain the levels in that range and prevent hypoglycemia. There are various definitions of hypoglycemia. I'll talk about them a little later on. These are the various common published used protocols. They've been developed in specific populations. It's important to understand each one of these has been taken from a specific population, a specific team of specialists have developed them. Are these applicable to everybody? There's a question mark there. So the ideal protocol is one which you make for your institution, for your set of patients coming to your hospital, and that's exactly what we've done. But all of them work really well, and one of the metrics of the any protocol is, you see in the Yale protocol, the infusion is started and then it comes down to a stable range. That's the target. Stable, not the yo-yo, hypo, hyper, like we all know about the sliding scale. We'll hear more about it when we talk in the non-critical care setting with subcutaneous insulin. But the desired result is stability in the zone of 140 to 180 for all of our patients. So will these protocols work for us? Some of these protocols are very intensive. There are two types of protocols. One are physician driven, other is a nurse driven. So Dr. Rujul said the number of patients we as a department see every day would range anywhere in between 100 and maybe going to 200 or more in a day. So is it possible for 1, 5 or 6 people to do that? No, it's not. So a protocol is one in such a setting where the volumes are very large, to have something which is semi-automated. It's an intelligent system which anybody can follow, and that's the kind of protocol we follow at our center, where it's a nurse driven protocol, very simple instructions. I'll show you the protocol here, and you would say this is the easiest thing to do. In fact, it's easier than the subcutaneous insulin protocol that we commonly use. So regular insulin has to be used, no other insulin, no NPH, no Lente, no basal in the infusion. It has to be regular. It's mixed with normal saline. I'll tell you exactly what we use, and you could copy the same in your practice. It has to be, now this is a common area of error. A dedicated IV route has to be there. Normally in the ICU you find a single IV line and a three-way connector there. There's an antibiotic going in one, IV fluid and the infusion. The best results would be obtained when the insulin gets an exclusive port of entry into the system for the most stable results of glycemic control. A very important caveat here is that potassium levels, please do not start an insulin infusion even in the emergency without having the potassium levels. Rather than causing benefit to the patient, this is an instant morbidity and mortality situation, which is hypokalemia. So we need to be very, very careful while using the intravenous route. Always have the potassium levels before you entail to start an infusion. Targets done. The monitoring is 1 or 2 hourly. Again, nurse driven. You have a chart in which the readings are noted. The infusion rates will be coming to that. How to change the dose? Very simple. See, by the end of this, all of you know how to really manage the intensive care settings. 2 readings above 200, you increase the dose as per the protocol which I am going to be showing. Lesser than the range, you bring it down, and hypoglycemia would be treated. If it is 60 to 90, you give 50 ml of 25%. Even lesser than that, first of all, you need to discontinue the IV infusion. And by the intravenous route, we all know, just as you stop the infusion, the effect of the insulin is gone. So that safety parameter is there. The first patient needs to come out of the hypoglycemia, that is consecutive readings above 100. And when they reach in the hyperglycemia zone, you start the infusion at a lower rate. Another very common error in the hospital is patient is on a high dose of steroids. Suddenly the treating team decides we need to, the steroids need to be stopped. You are not informed, we are not informed. But you get a call, the patient has collapsed. What happened? Hypoglycemia. Everybody is getting angry at the team treating the hyperglycemia. It is mandatory that any major treatment change which has a definite impact on the blood glucose levels needs to be informed, and the most common of that being steroids. Make a note in red. Do that. There's nothing wrong in that. so that the treating team also knows that when the steroid doses are changed, you are informed, you can descale the therapy regimen so that hypoglycemia does not happen. And that's the real success of managing inpatient hyperglycemia, the balance of hyper and hypo leading to a range of 140 to 180. This won't be very visible, but all that I've presented is in a printable form, and it's in the files of our patients in the ICU, easily readable. They know exactly at what levels, and once you do it like 10 times, it becomes instinctive. Okay, sugar 250, column 3 I need to go at column 4 after 2 hours. It comes below, it comes like 120, you come down a column. And this is exactly how you prepare the infusion. 50 ml, 50 units of regular insulin, only regular insulin, in 49.5 ml of saline in the 50 ml syringe in an infusion pump. Glucose insulin drips are no more used at our institution, but they are used for management of inpatient hyperglycemia where you don't have infusion pumps. But this is the most precise way to deliver insulin in an ICU setting. These are the columns which I talked about. We are starting with the least intensive column, which is 1. So patients like chronic kidney disease, chronic liver disease, very thin, frail, elderly patients whom we expect hypoglycemia to happen, or hypoglycemia may be very dangerous in this set of patients. You could start, or you should start, in the earlier columns, and in a very morbidly obese patient who is very insulin resistant, patient who is on a high dose of steroids, you know that whatever you do, they would require a higher dose. You can start with a column 5 or a 6 or a 7. As you start using these protocols, you know exactly in which patient to use which column. But the starting point should be insulin sensitive patient, come towards the right, insulin resistant, go to the left. And then you have an opportunity of changing the infusion rates during the hospital stay with a hourly or a 2-hourly blood glucose monitoring. And this is how the charting is done, the infusion rates. So when you're taking around in the hospital, you have this thing right in front of you. You know what has happened in the past. It helps you decide what to do now. You have the therapy chart with you. You have the patient in front of you. All of these things helps us. So you may just see the patient morning, evening, and you've taken the right decision to ensure that the glycemic levels are well maintained. So it is a nurse-driven protocol where the ICU nurses, in the ICUs mostly, there would be one or maximum, a nurse would be seeing 1 or maximum 2 patients. So they are dedicated to the patient, very easy for them to follow. Once they start using it, it's very easy. And in the journey of a decade being in Medanta, we've seen a drastic change in the outcome of our patients. And some of the data is also published about how well the protocols we developed in our patients, and whole lot of glucometrics, real-time monitoring, and lot of statistics and all went in to formulating these very simple protocols that you see here. An optimal protocol is one which is validated, like our protocol, which has been published already, and we've been using it for nearly a decade or more. It should be clear, it should be easy, it should not be intensive, not require calculations. The simplicity is equal to the success of a protocol. While you develop that protocol, there was a lot of complexity in developing it, but it translated into a very simple form of easily usable nurse-driven protocol. It should take into account the rate of change, and the monitoring helps us decide which direction to go with the column, the intensity. So there are several published protocols, but these are population based on teams, their specific group of patients they've been seeing. So that's how a real ideal protocol for your population comes. So the word ideal protocol is non-existent, is what works best in your population, in your institution becomes the ideal protocol. And we should, along with this, have the hypoglycemia directions how to manage it, which that sheet which I showed you has directions in when the blood glucose levels are this. Obviously, the clinical picture is number one, but then the levels of blood glucose tells you what to do in resuscitation from hypoglycemia. Transiting into subcutaneous insulin, well, all patients who are on large doses, they would require. In my experience, maybe 1 to 5% of ICU patients don't require insulin outside the ICU. Most of them, 95-98% require subcutaneous insulin once they're out of the ICU. Very briefly about subcutaneous insulin. The thing is, intravenous insulin has a very short half-life. So before you stop it or the patient starts eating, you need to give a subcutaneous insulin maybe an hour or two before that, in case the patient is not eating. But when you stop it, the blood glucose levels will go high. So classical example is transiting from the ICU to the ward. There would be a lag period of about an hour, 2 hours, maybe longer. In the ICU, the blood glucose levels was 176. When they reach the ward, it is 376. What happened? The nurse switched off the infusion, and because of the short half-life, the sugars escape. Patient is not eating. So in that patient, what should we do? About 3 hours prior to transport from the ICU to the ward, give a long-acting insulin. And very briefly, how to calculate the doses of that, I'll talk about. The last 4 doses of the infusion, just take them. That'll give you a good idea of the 24-hour requirement of this patient. Comes to 72. Don't give the entire 72 units. Subtract 20 to 30%. Here comes your skill, your understanding of the patient being insulin sensitive or resistant. Delete 10%, 20%, 30%. Mostly we do 20%. Give 50% as basal, and the rest 50 divide it into 3 in the bolus. Here you've got your insulin regimen which needs to be followed in the ward. So I end here. Hyperglycemia management in the hospital, including the critical care setting, has a direct impact on outcomes. In these sick patients in the ICU, it's mandatory, if the blood glucose levels are above 180, to institute glycemic control by virtue of a insulin infusion protocol given intravenously. The ideal protocol is one which is developed by you for your patients in your institution, and the easier form is a intuitive, easy protocol which nurses can drive in the hospital. So I thank all of you for your kind listening. Back to Rujul.
So thank you, sir. There couldn't have been a more practical approach as presented by sir for management of hyperglycemia in critical care settings. So now we move on to the next session. So there has always been an enigma about the best mode of monitoring blood sugar in hospital settings. To present this, we have our next speaker, Dr. Khalid Farooqi. Sir is a principal consultant endocrinology at Max Hospital, Saket. Sir will discuss about the mode of measuring glucose in hospital. Thank you.
Good evening, and thank you, Rijal. So I'll be discussing about the ways how we monitor glucose in the hospital setting. And when these slides were made earlier, whatever we have discussed so far, at that time the emphasis was mostly on the point of care glucose testing, and CGM was not into that much of play at that point of time. But now that in hospital CGM is being increasingly used, especially after the COVID, so there will be some discussion regarding that also. So in hospital blood glucose monitoring, basically we are measuring blood glucose as Dr. Sunil mentioned, blood measuring POCT or point of care glucose testing is a fifth vital sign, because every patient who gets admitted to the hospital needs to get their glucose checked. So just as we are measuring the other parameters, a blood glucose needs to be also checked. Now, it could be in the ward or the non-critical setting where the samples can be sent to the central lab, or you can use a glucose meter to do a point of care testing, or it could be through use of venous or arterial blood gas. In the critical care setting, usually it is done by the venous or arterial blood glucose, or point of care is also there, but then only few glucose meters are approved for use in the critical care setting. So remember that the glucose meter that is commonly used, not all of it is approved because to be used in the critical care setting. And then obviously there are multiple CGM devices. In India, we don't have that many at present. We are using mainly the Freestyle Libre and the Guardian Connect for this. So our results will basically differ from sample type to sample type. It will also depend on what assay we are basically using to measure that. And then there will be a difference between what results we get from the lab and what results we are getting from our point of care device. So the advantages here is that obviously you can use multiple specimens. It requires a very small volume, so you don't have to do a vinipuncture. And it reduces the therapeutic turnaround time because you can get the results in seconds. And that allows us to monitor the patient serially, especially in the ICU setting. When the person is on ICU infusion, we can measure glucose every 30 minutes or 1 hour, and we can get the results within seconds. Now, the limitation is that it will just give you a snapshot of the glycemic control. It's not going to tell us about any hypoglycemia that has happened, or periods of hyperglycemia can also be missed. So the challenges associated with the bedside glucose meter, we can divide it into three mainly. One is that pre-analytical, that is happening before the sample gets collected. The analytical, basically when the sample is being tested, and the post-analytical, that once the sample is processed and the data is fed. So mostly it is the pre-analytical errors, and it could be, and remember that it is mainly environmental and technique dependent. For example, in a glucose meter, if the strips are exposed, then it is a problem. Many meters which are like glucose oxidase based will give you a false result. If the technique is not, if the fingers have not been cleaned properly, then you can get a falsely high reading. And then you have analytical measures which basically depend on what assay is being used. Here, basically, the GDH methods are more sensitive to these fallacies. Then presence of certain drugs which are commonly used in the inpatient setting, like paracetamol or vitamin C, can affect the results. And then in the critical care setting, the alteration in the pH, hematocrit, and oxygenation, all these factors will basically affect the values. In the post-analytical, it's mainly whether you measured the glucose values. It was maybe around the 19 or 20, and it was like wrongly entered as 190. Then it can also be because of any verbal communication, basically. So mainly the pre-analytical errors can be, you can basically reduce it through calibration. You can reduce it by using individually wrapped strips. Some companies do have those. Then usually the barcoding can also help, so that the wrong patient ID is not created. So you only enter the values which are there. So there are some glucometers which will wirelessly transmit the data to the central server. Now, the other thing is the endogenous interferences like hematocrit, hypotension, electrolytes, PO2. All these are mainly come into play in the critical care setting. And then exogenous, like the ascorbic acid, acetaminophen, they come into picture in a routine ward also, where these are commonly used. So to just give you an example, a simple increase in hematocrit will increase the, if the hematocrit is increased, the values will be low. If the hematocrit is decreased, the values will be high. Then in presence of, say, hypothermia, the values can be slightly increased. Then vitamin C can increase both in the glucose oxidase as well as dehydrogenase method. And in case of acetaminophen, it will again increase or decrease. The thing is that all these things will come into picture when you actually have to think about it, because all the different glucose meters will have their product insert. So you'll have to individually go through them to exactly find out what is the range where they are safe and at what range they are unsafe. Then patients who are on peritoneal dialysis, their icodextrin and maltose is being used, and there are reports of fatal hypoglycemia because the glucose meter falsely recorded high readings, and they were given insulin infusion, leading to fatal hypoglycemia and death, actually. So all these things have to be kept into mind. So we discussed that we need good glycemic control, but are we measuring it correctly? And if we are measuring it correctly, what is the impact? Because as you know, in trying to achieve a good glycemic control, if there is a fatal hypoglycemia, it will be an adverse event. So we had seen in the earlier slides about the various trials which have been done in the critical and the non-critical setting. So till 2010, there was not much emphasis on the type of glucose meter being used. After that, once the nice sugar came, then basically one of the fallacies which was basically being discussed was it was a multi-centric study, but those centers used whatever means was available to them for glucose monitoring, right? So it was not a specified method. So that could also have led to some variation in the results. So after that, the FDA approved basically the StatStrip glucose meter for use in critically ill patient. That too, only venous, arterial, and heel stick blood sampling was allowed. It did not allow capillary glucose testing. But now even that is also being allowed. So I'll skip this. Yeah. So for glucose meter performance, it is important that currently, if 95% of the total measurements with the POCT glucose meter should agree within plus minus 12 of the lab analyzed value, which is if it is the blood sugars are less than 75, or it should be within 12% of the lab analyzer value if the sugars are more than 75. It is important that we define the gold standard. So what is the gold standard? So gold standard obviously would be something like an IDMS, where it is an isotope basically dilution method. It's not available. The other is that your central lab basically does it through the hexokinase method. So that is something that can be used. So then just a meta-analysis or review of the accuracy of blood glucose measurements. It just mentions that the capillary glucose testing will be inaccurate, especially in the younger age, where there's a low perfusion index, vasopressor use, edema, and it is not associated with albumin, lactate, and pH hematocrit. So all these things are commonly seen in patients in the critical care setting. So these are the various basically brands of glucometers which are available along with the methodology. And you can see in the StatStrip, there is no hematocrit range. So it adjusts for the hematocrit and it gives you the correct value. So these are different, not all of them are available in India. We have the iStat here, Abbott iStat is available, and the StatStrip is available in India. So as I mentioned, the icodextrin in the peritoneal dialysis led to severe hypoglycemia and death. Then the point of care testing where the hematocrit and ascorbic acid has also led to falsely increased values. So hematocrit, as I mentioned, a high hematocrit will lead to a falsely low value, and a low hematocrit will lead to a falsely high value. So there are methods to address the hematocrit effect. For example, the StatStrip has another electrode that basically measures the hematocrit directly, and it adjusts. The other thing is that some of them which are used in the ICU, basically like a HemoQ, will lyse these cells. Because when we are basically puncturing the or you are using the finger prick, you are using a whole blood sample where the lysis has already taken place. So all these glucose meters will work only with a whole blood, which then gives you a plasma equivalent value. They are not going to work on serum. So the thing is that now that we know that at certain situation we cannot use these glucose meters effectively. So there is one criteria called BRAVE criteria, that if your blood pressure is less than 80 by 50, or the capillary refill time is more than 3 seconds, if there is acidosis like ketoacidosis or hyperosmolar coma, if there is a use of vasopressors like which is exceeding for dopamine more than 5, or if epinephrine more than 0.6 micrograms per kg per minute, or if there is edema at collection site, then one should avoid using the glucose meters. So because you'll always get false results, and starting insulin infusion or giving a dose of insulin in such a situation can be erroneous. So always either confirm through the central lab or use some other methods, maybe like a stat strip or iStat method for measuring the glucose values. So to conclude from the POC glucose testing, that it is the standard of care to assess glycemic control currently and to adjust the therapy, but it fails to provide you the 24-hour glycemic profile assessment. And it does not detect any asymptomatic or nocturnal hypoglycemia until unless it is tested for the same. And it is labor intensive, prone to errors, and there are mismatched measurements, especially in certain situations. So what solution do we have here? So one is that we can use the continuous glucose monitoring system. So it can be of various types, like invasive, like intravascular venous or arterial being used. Now not that popular because our sensor technology has improved, and even with transdermal and subcutaneous, we are able to get reliable results. And then sampling frequency can range from 1 minute to around 15 minutes. So one is a real time, which will give you continuous data, and it will transmit the glucose data in real time. One is intermittently scanned, like you have the Freestyle Libri where you scan and you will get the result on the screen. And there is one integrated way where this device basically will communicate to the automated insulin delivery system. For example, if the patient is wearing a insulin pump, or if you have a automated insulin delivery system like a glucocommander, then that will be utilized here. So CGM metrics basically is 3 or 4 things. One is the time in range, which should be kept above 70%. And then time below range, that is to avoid hypoglycemia, less than 54 should be less than 1%, and time above range, that is more than 180, we have to target it to be less than 25%. So as we have seen in the previous talk also, that basal bolus is the way to go in the inpatient setting. So whether we can utilize the point of care, the continuous glucose monitoring system in this setting, we'll see in the next few slides. So the timeline, as I mentioned before COVID, there were small studies. It is just after the COVID struck that people became more interested in this technology because one, it allowed us to monitor remotely, and which was the need of the hour at that time. And so in the last 2 years, there has been numerous publications regarding this. So these are the CGM systems that is available. So you see, whatever was basically applicable to the glucose meter is applicable here also in terms of their interference. And especially salicylic acid, ascorbic acid, and then in some situations, mannitol and hydroxyurea. So here what we are using is mainly the Freestyle Libri. So only Freestyle Libri is available. Libri 2 is not yet launched in India. So some of them are factory calibrated. So you need not kind of measure the glucose meter with the point of care in the hospital. There is a warm-up time. It will not give you readings immediately. You have to wait from 30 minutes to 1 hour for a proper assessment. So the various trials have been done. So I'll just mention. So in critically ill, the meta-analysis has showed that using CGM mortality was reduced. Most importantly, hypoglycemia incidence was reduced. But overall, the time in below or above target glucose range remained the same. So hypoglycemia avoidance would be the key here. Then limitations would increase that if you're using intravascular, then there is a risk of infection, thrombus formation, then cost, and then the same interference that we saw in the glucose meters would come into picture here. In case of the, I'll show you this one, the basically non-critical setting, that is in the ward setting, there are various studies that have showed that basically, for example, in this study, the Dexcom G6, the MARD, which is basically used to measure the efficacy of a CGM, was less than 10. So if you are able to achieve that kind of control, then that means you can safely use that in the inpatient setting. So the challenges is at this point of time, there is no regulatory approval. There is then obviously these interferences will be there. So what will be the impact in case of hypotension, hypothermia? If the patient is shifted for procedures, X-rays, we don't know what will be the impact. And then overall, the best thing is that one is we have found is that hypoglycemia incidence and identification of hypoglycemia has improved. Overall, the hypoglycemia has improved, but overall the glycemic control has remained the same. Okay. So to conclude, this will offer a basically digital care. It will allow us to intelligently modify the pharmacotherapy, but it will require an ongoing validation. So that is important. So if you're using CGM, do use a point of care glucometer also. That is a hybrid mode, so that you can confirm any abnormal findings. Thank you.
Thank you, sir, for taking us through to the journey of monitoring glycemia in inpatients. So now it's time for panel discussion. So I invite the panelists, Dr. Sunil Mishra, sir, and Dr. Khalid Farooqi, sir. So we can take up the queries from the audience also. So I start with Dr. Mishra, sir. So, sir, you oversee management of hyperglycemia of around 100 to 150 patients daily. So, in your experience, what all and who all are required for an optimal inpatient hyperglycemia management?
So I think it's a team effort, right? So and individually it is very difficult. Whenever we have worked individually, we have tried to help good glycemic control. It is very difficult. So we have seen step-by-step change in management of in-hospital hyperglycemia. We have more number of the doctor in team. We have the resident doctor, and the care really improved after we have the DNB doctors who are pursuing the endocrinology course in our team. So because they are well learned people and they know about and they are interested, and they are 24/7 available in the hospital. Afterward, the next step was the diabetes educator. So diabetes educator really fills the next gap for the in-hospital glycemia management. So many a time patients are going discharged without any particular advice. They are not aware about the insulin injection. For 5-7 days, we have done a good glycemic control, but of course, when they reach home and they are not aware about the usage of the insulin. So it's not only a consultant, but the team of the doctor that required for the in-hospital hyperglycemia management that I discussed in the presentation. It's not very difficult. I will tell you, it's not very difficult. We have a large volume hospital, so we need more people. But just identify your hospital when you have a set of patients. So if you have a 50 bedded hospital, of course, then 20 patient will be having diabetes, and you have to have a good diabetes educator. So we can help you in getting your diabetes educator trained for the diabetes management. We run a course in our department. So diabetes educator course is for 6 months, where they get hand-on experience about the diabetes management in hospital as well as the outpatient setting. And then of course learning is a continuous process. So every day we become wiser whenever we see more and more patients. So this is how we are here in discussing the in-hospital update for hyperglycemia management. Thank you.
Thank you. So the next question is to Dr. Khalid sir. Sir, you cautioned the accuracy of POC meters in inpatient hyperglycemia monitoring. So according to you, should there be a protocol that at certain point of time the POC meters should be calibrated with venous blood?
So I think in all hospitals, the biomedical engineering calibrates these glucometers regularly. Huh. So these meters are being calibrated regularly by the biomedical team. Okay, and especially if you get abnormal readings, you should question. Don't take all these values at face value. Okay, so we have seen during COVID with vitamin C what kind of hyperglycemia was found, and a patient was absolutely normal, and a glucose meter would give a reading of 540. Patient was just sitting comfortably, and we sent a sample, a blood gas sample. It came out to be 78 or 80 in that range. So whenever in such a scenario, if it is not kind of meeting the clinical endpoints, or like if you find that it needs to be questioned, I think a venous sample should be drawn. We should not act hastily just on the basis of a single glucose value.
So the next query, as we have seen that intravenous insulin infusion is the standard of care for critical ill patients, but if in any facility there is no, the intravenous insulin infusion is not feasible, so can intermittent subcutaneous insulin be used in critical care settings?
So it will be very difficult to control the hyperglycemia, especially by the intermittent subcutaneous insulin dose, because it takes time. Then there is absorption, peak time, and the pharmacokinetics of the subcutaneous insulin is entirely different from the pharmacokinetics of the intravenous insulin. I think after say last 15-20 years, there is a sea of change. The insulin infusions are readily available in most of the hospitals. They do not cost too much, and it is very easy to use those insulin infusion pump rather than giving the subcutaneous. But of course, when you don't have anything in a very stressful situation like during the COVID, when you are not having anything, so giving insulin is right. You have to give the basal insulin, but only take away a message from giving subcutaneous insulin is that basal insulin should be given. You should not consider to give sliding scale insulin, which of course will be discussed by Dr. Parjeet in subsequent discussion, why the sliding scale to be avoided. So basal insulin has to be there, and then you monitor the glucose frequently. Then you can give intermittently the bolus insulin as per the glucose level, and try to maintain a steady state of the insulin level and the glucose level, and avoid hypoglycemia.
So I'll just make one comment. So my practice has changed when I was at Medanta, because there I could use the insulin infusion in the floor also. Now in my hospital, I am not allowed to use insulin infusion in the ward setting at all. So it's not, the administration does not allow the use of infusion on the floor. The person has to be in the HDO or ICU for any such infusion. So in that scenario, yes, the workaround is to use intermittent bolusing. Obviously, with the help of basal and bolus, I'm able to control it in a fairly okay manner. So it all depends on the institution, the administrative support, because the it was like if it is 500, you start infusion. So now if it is 500, I cannot start infusion. So I have to go by maybe short boluses over the next 2 to 3 hours to control that. So yes, we'll have to kind of adapt to situation. No IV, subcutaneous boluses, subcutaneous, no IV.
So, Dr. Khalid, just one point I would like to make.
Yes.
So you're telling that it's the the administration point of view, but should with the discussion should be from the the evidence based, and what should be the correct way of giving the insulin,
So hospital
rather than
thinks
saying
that,
it's the
no, the thing, no, it's not about the cost. It's mainly about
No, evidence,
hypoglycemia.
I'm just saying evidence based. So if this sugar is like 500, should we give it insulin infusion rather than
So
saying
see, that 500 has to be accompanied by certain other clinical sets. Okay. So if 500 is with diabetic ketoacidosis, definitely that is a different scenario. But in a normal person who a 500 who has say a pretenor of 500, not everybody would need to be shifted for infusion. So if he is clinically okay, I would manage him with subcutaneous boluses also.
so it depends on from the clinical status.
Yeah, so I can get a venous blood gas at that time. I can get the stat plasma ketone at that point of time and decide about that. So I think obviously it will be on the basis of the other clinical factors. But because all these either insulin or IV infusions, so IV calcium gluconate or even potassium, it's not allowed on the floor.
So it depends upon where you are working.
Yeah.
True.
Even in NHS also infusion, variable rate infusion, where they have certain things like glucose, like you have to kind of infuse glucose along with insulin so that there is less risk of hypoglycemia. The flow, it is not allowed on the floor. It has to be either in the HDU or ITU or the ICU.
But ideally, if you have opportunity, you would like to eat insulin.
Yes, definitely it is
More convenient.
convenient, yeah. But then we have to see the practical aspects of it.
Right, sir. So the next question is to Dr. Khalid, sir. So according to you, what is the utility of CGM devices, especially in critical care settings?
So as such, see the thing is that in patients where I want to minimize the number of pricks where the glucose values are fluctuating too much, in that scenario definitely I would be using that. But then as you had seen, there are so many other factors which are affecting the accuracy. In that scenario, it doesn't look, gives us a very pleasant outlook. Okay, so maybe in the sometime later when we have more data to be used, definitely it will have a lot of kind of bearing on the ICU outcomes also. We have seen that it identifies hypoglycemia as well as lowers the hypoglycemic events because you are able to see that will be possible when you are using a glucometer which alerts you towards that. So if it is signaling that okay, if after 15 or 20 minutes the glucose can go to that extent, some corrective action can be taken. So it can guide us, especially in those who are on insulin infusion, type 1 diabetes, who are on pump. Definitely, it will be very useful in that setting.
Right, sir. So this is definitely an area for future research.
Yes.
So next question is to Dr. Sunil Mishra, sir. Sir, you highlighted the important role of diabetes educator in patient hyperglycemia management. So how can we utilize admission of a patient for proper diabetes education?
So any question from the floor is also welcome. So please take your opportunity to ask the question. So the diabetes educator really fill the gap in the inpatient diabetes care. So when you have a diabetes educator who is well versed with the diet, insulin, hypoglycemia care, so it really off burden you from the large set of the in-hospital hyperglycemia care. So earlier days when we have to call patient to the floor for diabetes education, so there used to be a a little bit of the pressure on the diabetes educator when they used to come to floor, and many a time because of the nursing pressure on the floor, patients were not visiting to our floor for the diabetes education. So now what we have the change, we have changed the policy that all patients are seen then and there by diabetes educator in the floor itself. So before the discharge alert goes to the diabetes educator. So they take care of the diet part as well as the insulin part, monitoring hypoglycemia, and in the discharge advice we tell them when to follow. So this closes the gap which I was talking about the discharge, because this discharge advice is very important. As I discussed, OPD glycemic control is poor. So the type of the patient who is coming to the hospital will always come with the poor glycemic control. You have a window of opportunity in 5-7 days to show at least 140 to 180 glycemic control and allow patient to go in a good glycemic level. So I will give you one example of one of the patients. So this situation is very difficult. So one patient was planned for a neurosurgery. His glucose level was 300, and when we did the HbA1c, this is the highest HbA1c I have seen, is 21. And I discussed with the neurosurgeon that we need a good glycemic control, at least give me 2 week time so we can get the surgery. So he told me that patient is from Doda, Jammu and Kashmir, and he will go back in next 3 days. So I have to do the surgery. So yes, so this was a challenge. So I told them then we have only opportunity to start the insulin infusion. We control the glucose and discharge patient on multiple shot insulin. Followed the patient in remotely in OPD basis. Patient did well, and of course then a loss of follow-up after 6 months. So most important part of the in-hospital hyperglycemia is the perioperative glycemic control or peri-procedure glycemic control. Many a time people who come in the hospital, the outcome goes well with the not only with the HbA1c but more with the peri-procedure during in hospital and after discharge, how well you've been able to held the glucose level in control. And for that you need a team, and the team the soldier of the team are the diabetes educators.
Yes, sir. So the next query is to Dr. Khalid, sir. Sir, as we have seen that transitioning a patient who is on IV insulin to subcutaneous insulin, there are many errors. So according to your experience, what practical tips would you like to give to transition a patient from IV to subcutaneous insulin?
So whenever we are see, IV to subcutaneous will be happening in the ICU setting once the patient is planned for ward shift. Now usually that happens after the morning rounds. So if you are there at that point of time, because say if you are taking rounds at 9 or 10, at that point of time you can order for the long-acting insulin to be given at that. So it will depend on various other factors. What has been the previous glycemic controls? What is the overall oral intake at the present time? Any other things, whether patient is on steroids. So as we had mentioned that that there is one thing that you take into account 24-hour picture or the last 6 hours or 4 hours. There are various patterns. Each one is kind of can be followed. So the best thing would be to give a basal insulin at the time of rounds itself, so that allows us to that even if the patient gets shifted, say in the afternoon or evening, you will have some control, because in the intervening period, part of the infusion will be missed. And so rather than again receiving a call that the glucose values have rose up to 400, with a basal maybe it will not kind of climb to that. So I think at the time of rounds, usually what I do is that I give a basal shot at that point of time. I discontinue the insulin after an hour or so, and then write the bolus component at that point of time.
So thank you, sir. If we have any further query from the audience. If there are no further queries, I once again thank all our panelists for their valuable input. So moving on to the next session, the next subset of inpatients are patients who are non-critical ill. So to present management of hyperglycemia in non-critical ill settings, we have Dr. Parjeet Kaur, ma'am. Ma'am is a senior consultant at Medanta. So over to ma'am.
Thank you, Rujul, and a very good evening to all. So, managing hyperglycemia in non-critical care setting can be challenging because we have mixed bag of patients with us. Variable diagnosis, the variable intake of food, uh, pre-op, post-op. So there are variety of patients of multi-specialities, and we know that diabetes is an individualized treatment. So we kind of try to individualize each and every patient to manage their hyperglycemia, and it can be actually confusing. But the thing is that in the hospital management, we really do not have to individualize that much. So we have to just follow a certain protocol to manage these patients, and that will definitely give a good outcome. So my job here is today is to present those protocols which can be easily used anywhere you are. It's not only that these protocols are used only in tertiary care setting where we have multiple support system, we have educators and everywhere. No, it can be used in a very small setting also. Because once you follow a certain protocol, no matter what kind of patient is it, whether patient on steroid, major surgery, minor surgery, infections, you can easily manage the blood glucose. So I'll start with this case. This is a routine case, 40-year-old diabetic, 40-year-old male is no history of diabetes actually, admitted in the medicine ward for the workup of PUO for 3 months durations. His appetite is mildly reduced. His random blood sugar on admission is 150. His creatinine is 1.1. HbA1c was found to be high. 24-hour blood glucose values when checked by the glucometers, day 1 showed these readings. So how will you manage with this case? Will you start oral anti-diabetic agents, or will you put this patient on sliding scale insulin, start basal bolus, start premix, or start only basal? So we have all these multiple options. I'll come back to this question at the end of my talk once I run through all the slides and give you the evidence for the management of hyperglycemia in non-critical care settings. So once the patient gets admitted, we have certain questions in our mind, like what are the factors which will decide the treatment of hyperglycemia in these patients? What are the glycemic targets? How should we manage hyperglycemia in non-ICU setting? And then I'll come back to the case studies and finally the summary. Now, what are the factors which decide? There are multiple factors which decide the treatment. What kind of diabetes the patient has. It's very, very important to differentiate at least between type 1 and type 2, because type 1 patient is the one who will require insulin round the clock. So this can happen, this mistake can happen, that type 1 diabetes patient has been admitted in the ICU for some other reason. Patient is given insulin infusion according to protocols, variable infusion rate. Once the blood sugar is below 100, insulin infusion stopped. Patient will land up into diabetic ketoacidosis. So this is a huge difference between type 1 diabetes and type 2 diabetes. Type 1 diabetes patient will still require insulin infusion even if the blood glucose is less than 100, although at lesser rate. This patient, even if in the non-ICU setting also, even if the appetite is low, you keep on monitoring, do not skip insulin. Even if small required dose, give it. Even if only basal, give it. So do not skip insulin type 1 diabetes. Second factor is patient's current blood glucose concentrations. Of course, it's very important to decide. Little bit high, you can manage with maybe a small dose. Higher, you will definitely need a higher dose. Prior treatment is very important. History taking is important. What patient was already taking. If the patient was taking of almost 8 milligram of sulfonylurea with 2 grams of this metformin and SGLT2 inhibitors, almost full dose of all the drugs, and patient gets admitted, and you put the patient on a very small dose of insulin, let's say 10 to 15 units a day, For 1 or 2 days, patient will be fine because sulfonylurea is still acting. The moment the action is gone, the sugars will start rising. So keep in mind what kind of treatment patient was on, and on that treatment, what was the HbA1c, how the control was, and then you decide the insulin dose accordingly. Severity of illness, of course, is important. Severe the illness, you would want to be more aggressive in controlling the blood sugars. Expected caloric intake during the acute episode, because that will alter again the management. I'll come back to this later on. Associated comorbidities, whether the patient has associated CKD, CLD, CAD, or if the patient has developed acute kidney injury, that will again affect the insulin sensitivity, and then we will alter our management accordingly. So what are the glycemic targets? The first thing is very clear that you start the treatment once the patient is admitted and the patient has persistent hyperglycemia which is more than 180. So if the readings are, you start monitoring, if the readings are staying below 180, you can still monitor and without giving insulin. But once the readings start shooting up beyond 180, you need to start the treatment immediately. Also, if the patient is on prior treatment, you have to continue even if the blood sugar levels are below 180. Target the blood glucose range between 140 to 180. This is same as we saw in the critical care setting. This is basically derived from the critical care setting studies only, but extrapolated to the non-critical care also. This is to safeguard us from the hypoglycemia. So broadly, the target is to keep the value somewhere between 140 and 180. And therefore, you modify the therapy when the blood glucose start falling less than 100 to avoid the risk of hypoglycemia. However, more stringent targets, like you can keep 110 to 140 also in stable patients who already have a very good glycemic control in the past, HbA1c of 6.57 and no history of hypoglycemia, you can target very well. And the less stringent targets should be appropriate in patients with severe comorbidities, CKD, CLD patients, pancreatitis patients. These patients can still manage where they're more prone to hypoglycemia. Keep it somewhere between 180 to 250. Even in terminally ill patients, you can go beyond this, 1 to above 250 is also acceptable. So these targets can be, they are different in different kind of set of patients. Now coming on to the what kind of pharmacological treatment is suitable for managing hyperglycemia in non-ICU setting. We have subcutaneous insulin, which is the recommended one for the most of the patients. Oral anti-diabetic agents are generally not recommended. However, there are certain oral anti-diabetic drugs which can be given, which Dr. Herman will cover up in her talk. But majority of the patients will do good on subcutaneous insulin. As we discussed just that continuous IV infusion, preferably not in the ward, should be not be given because of the risk of hypoglycemia. But here in Medanta, we are giving the full supervision, keeping the eye on the blood sugar levels every 1 to 2 hours. We are able to manage. However, if you do not have that kind of support, then do not try to attempt give IV infusion in the ward. In that case, multiple boluses will be preferable. So what kind of insulin therapy? We have basal bolus therapy, where we're giving a rapid acting insulins along with a long acting, or NPH with a regular, premix or a sliding scale insulin. Basal bolus therapy is the preferred mode and is being endorsed by all the societies and is recommended as a preferred therapy. Sliding scale is absolutely no. It's strongly discouraged, and I will run through the next 2 to 3 slides why I'm saying so. Premix insulin in a very selected group of patients where you know that patient's going to be there for you for just for a day. Earlier the patient was well controlled on premix, he's eating well, stable patient, you can just continue for a day with the same dose and go away with it, but majority of the patients will do good on basal bolus therapy. So this is an example of a sliding scale. What you are doing here is when the sugars are going below 180, you're not giving insulin. As the sugars are rising, you are just adding on the insulin, 2 units, 3 units, 4 units. When the sugars are very high, you're straight away giving 10 units. What is this called? This is a reactive approach. We are reacting to the blood glucose levels. And what's happening as a result of this reaction? A roller coaster effect is being created, where you can see here when you're not giving insulin when the blood sugar was completely normal, the next blood sugar rises because the patient has eaten something, no insulin given, blood sugar increases. Now you give insulin, okay? Now blood sugar drops suddenly and there is a risk of hypoglycemia again. Again, you will not give insulin because sugars are normal, the gain will rise. There's a roller coaster being created, as opposed this is a physiological insulin secretion which is there, where we really need to, the body secretes insulin right before and the meal, and then this how the blood sugars are controlled. So this kind of roller coaster are prone to give both hypoglycemia as well as hyperglycemia, and this is not going to give you good glycemic control at all. And there is a clear-cut evidence for this in this study, where a basal bolus was compared with a sliding scale, where we have a basal bolus here of a, and the closed dots and the open dots are the sliding scale, and the two groups when compared, clearly the group which was put on the basal bolus had a very good glycemic control, and when these patients on sliding scale were switched over to the basal bolus, they achieved a very good glycemic control. So we are talking about here evidence-based, recommended one. Sliding scale is absolutely no in patients with in patients admitted with the hyperglycemia in the hospital. So what are the subcutaneous insulin options we have? We have basal, bolus, and the correction insulin. The basal insulin is the one which will mainly control the blood glucose in the fasting state, in which we have available with us NPH, Detamar, Glargine 100, Glargine 300, Degludec. More about basal insulin, Dr. Shafi will talk about. Then we have bolus or the prandial insulin. This is the insulin which we give prior to the meal, which will blunt the rise in the blood glucose following the nutritional intake. This could be a short acting like regular insulin, rapid acting or ultra rapid acting is also available now, or a correction insulin. Correction insulin is the one which will correct the hyperglycemia due to the mismatch in the nutritional intake or the other illness related factors. For example, the patient was not expected to have this much because patient has eaten less or eaten more. Now the readings are high. You will correct for that so that next reading also is in the range. I will show you what the correction dose in the example. So bolus insulin injection should align with the meals. This is very important. It's not that you've given the injection, patient has not eaten, and then there's going to be huge mismatch there. Therefore, the monitoring should be performed immediately before the meals when you're planning to give the insulin. And another important point is, if the oral intake is poor, a safer procedure is to administer that insulin or a bolus insulin immediately after the patient eats. That is also a possibility with these analogs, or even the faster analogs like faster aspart we have. This possibility is also there. So you can choose that option as well. So how do you decide the dosages of a basal bolus in a non-critical care set? This is the broadly a gross idea about it, where you can easily follow this. Usually when the patient is normal weight, the total daily dose decided is around 0.4 to 0.5 units per kg of the ideal body weight. If the patient is obese, which means that patient is insulin resistant, you will give a little higher dose, 0.5 to 0.6 units per kg. Lean patient or a patient who has CKD, renal compromise, CLD patients, you will give a little lower dose, 0.3 to 0.4 units per kg. So first thing is to calculate the total daily dose. And then you divide this total daily dose between the basal, 50% basal and 50% bolus. That's a gross idea, 50-50% you can divide. And then the further bolus insulin is divided equally between the three major meals. Then you measure the blood glucose level 4 times a day at least. 3 pre-meals, that's fasting, before lunch, before dinner, and 1 is at the bedtime. Based upon these blood glucose measurements and the insulin sensitivity factor, we decide the certain correction dose. And based upon the fasting plasma glucose, we then titrate the basal insulin dose. So let's come back to this case again. So here the key messages goes here in this case is that patient had no history of diabetes, but on admission blood glucose was 150, which is clearly above 140, which defines that the patient has in-hospital hyperglycemia. One definition is clear. Second, you get the HbA1c. It's important to differentiate people who have pre-existing diabetes from who have stress hyperglycemia. The management will differ in that, at least at the time of discharge planning. So this patient had high HbA1c, which means patient had clearly a pre-existing diabetes. Third key message is that the patient start monitoring, blood sugars are high, majority of the values are above 180, that means patient warrants treatment. Fourth key messages is now what treatment? Definitely patient will need a basal bolus insulin regime. So how to decide? This patient had a weight of 80 kg. This patient is a stable patient. Creatinine was also normal. So we decided to give this patient a 0.4 unit per kg, which comes out to be 32 units in a day. And this is how the correction doses are decided. Where you decide that somewhere you want to keep this target range, you give the same dose. Otherwise, if the blood sugar levels are going low, you subtract from the decided dose. If the blood sugar levels are going high, you add on the decided dose. So you decided this dose of 32 and divided into 50-50% as a bolus and the basal. And bolus you divided again between 3 meals. And these are the readings on the day 1. As you can see here in the before lunch when the sugar was high, so we gave some correction here so that the next reading comes back to normal. If you do not give any correction here, the next reading will also remain high. So this is to adjust for the unexpected hyperglycemia at this point of time. So day 2, what you had done is, because you know that the fasting is coming high, you have stepped up the basal insulin here. And what is you're getting the day 2 is a little better fasting, but you continue to have here a before lunch, which is blood sugar is high. Again, you gave a correction. So on day 3, to correct this high blood glucose at the lunch time, you have actually stepped up the breakfast dose. So breakfast dose will take care of the lunch blood glucose. So this is how you have done. And this is the final readings. This is how smoothly the blood sugar has been controlled. Just last 2 slides upon the 2 special set of population. How do you manage the hyperglycemia in CKD patients? Because these patients are prone to hypoglycemia. They're very much insulin sensitive. So in these cases, you use both EGFR as well as the weight of the patient while calculating the total insulin dose. So mostly they will use the lower side, 0.3 units per kg per day. And you always down titrate the home total daily dose in these patients. So mostly these patients are already on insulin when they're getting admitted. So you down titrate to 25 to 30%, you give less dose in the hospital because their appetite is usually reduced, they're suffering from some illness. Night dosing in many of these patients is actually not required. So many of these CKD patients do well with just very small boluses of, let's say, 4 and 2 units given before each meal. Basal insulin many a time leads to hypoglycemia, and then so we can avoid. And especially at the time of dialysis, it's important to reduce the basal insulin by at least 25%. And even you can skip the pre-dialysis bolus if it's a very small dose like 4 to 6 units, or if it's a large dose, you can reduce to 50%. Then there are patients who are on RT feeds. For example, this lady who has CVA, she's on RT feed 100 ml 2 hourly. These patients can also be managed very well on subcutaneous therapy. For example, the planned feeds are 9 feeds, although you do not have to give before every meal because one insulin is at least going to take care of 4 hours. So you start with the first feed, then give at 10 a.m., 2 p.m., 6 p.m. The last short acting should be at least 4 hours prior to the last feed, which was given at the 10 p.m. And at the bedtime, you give a basal insulin. And the correction will also remain same. Maybe you can give a little less correction here if these patients are having blood sugar on the lower side. So the take-home messages from this talk is that first thing is, upon admission, assess all patients for history of diabetes. Obtain a blood glucose testing. Even the point of care testing is good enough to define whether the patient has in-hospital hyperglycemia. If blood sugar is high, if the patient already has diabetes, you do check for HbA1c. Target a blood glucose in the range of 140 to 180 for most of the patients, but it can be individualized as I told earlier. Insulin therapy is the preferred method of the glycemic control in hospital, and scheduled subcutaneous basal bolus is effective and safe. Sliding scale regular insulin is completely inappropriate and should be strongly discouraged. Thank you so much. I give over to Dr. Rujul now.
So thank you, ma'am, for such a lucid presentation. Now we move on to the next session. So in the past few years, we have in our therapeutic armamentarium second generation basal insulin. So how we can utilize second generation basal insulin in inpatient hyperglycemia? To deliver the talk, we have Dr. Shafi Kuche, sir. Sir is a senior consultant endocrinologist at Medanta. Over to sir.
Thank you, Dr. Raju. Good evening, everybody. So, as you have heard from Dr. Parjit, that basal bolus regimen is the, is the treatment of choice in patients with hyperglycemia in hospitalized patients. And in that basal bolus regimen, basal insulin is the backbone because it consists of about 40 to 50% of the total daily dose of insulin. So what are various basal insulins available with us? We know that NPH was, it came into market in 1950, and for next one, Glargine U100 came in 2000 only. So for 50 years, it was only NPH that was used as basal insulin. So there was no comparison with other insulins. Then when we had Detimir and Glargine U100, we had then studies and compared NPH with other long-acting insulins. This was the first study in which Detimir, which was a long-acting insulin, was compared with NPH. And in this study, Detimir once daily and aspart before meals, usually 3 doses before meals, and it was compared with.
Yes, please. The slides are not coming.
Yeah.
From beginning, Shafiq.
Yeah, there's only one slide. So these are the various basal insulins. So this was the first study in which long-acting Detimir was compared with NPH as a basal insulin in hospitalized patients. In this study, Detimir was used once, and 3 doses of bolus as aspartate was given, and it was compared with NPH and regular insulin 2 doses. Glycemic control improved similarly in both groups, but there were 33% patients in Detimir and 25% patients in NPH group had at least one episode of hypoglycemia during the hospital, which was not different. So it showed that the Detimir and NPH as bolus doses were similar. So next, then Glargine U100, which is commonly used nowadays, was compared with NPH. In this, Glargine U100 once daily was used, and the bolus was glulucine before meals 3 times. It was compared with NPH twice daily and regular insulin before meals. Glycemic control improved similarly in both groups. Prevalence of hypoglycemia was 35% in Glargine group and 38% in NPH group. Severe hypoglycemia, that is blood glucose level of less than 40, 7.6% with Glargine and 25% with NPH, which was more. So there were more severe hypoglycemia with NPH. So after that, another study came in which Glargine U100 was compared with NPH, and NPH here was as a premixed insulin that we usually see, for example, premix 3070, which is commonly used, and that was also used in this study. Glargine U100 once daily and glulucine before meals was compared with premixed human insulin 3070 twice daily. This trial was stopped early because 64% of patients in the premixed group had hypoglycemia compared to only 24% patients in the Glargine group. So this trial was stopped early, and then it was strongly suggested that premix should not be used in hospitalized patients for glycemic control. So after that, because both with NPH as a separate dose and with premix, there were more hypoglycemic events. It was then Glargine U100 became the basal insulin standard of care for inpatient management of hypoglycemia, and NPH, particularly as a premixed insulin, it cannot be used via the analog availability and affordable. It can only be used when you don't have that analog Glargine or Detimir. So then we have now 2 long-acting analogs like Glargine U300, and in this study it was compared with the standard of care Glargine U100. And you can see from the graph the glycemic control was similar with both Glargine U300 and Glargine U100, but hypoglycemia were also statistically not different. But you can see, for example, blood glucose less than 70, 8.7% patients with U300 and 9.5, which is not different. But with glargine U300, there was no hypoglycemia below 54 milligram per deciliter, while 6% of patients had hypoglycemia less than 54. There was slight, less frequent hypoglycemia with glargine U300. Then we know that degludec U100, it was compared with glargine U100. So in this study, again, both insulins, they control glycemia equally, first graph. And second, you can see there was no difference between breakfast, before lunch, before dinner, and bedtime glycemia. And there were no differences between hypoglycemia in the two. 17% in patients had hypoglycemia in degludec, and 19. These are not severe hypoglycemias. These are less than 70, but not less than 54 or 40. So overall, the two insulins were similar, and there were less hypoglycemias. So we did this study in which we compared degludec U100 with glargine U300. That is the ultra long acting two. We compared them head to head. So we did this study in type 2 diabetes patients who were planned for CABG. We randomized 239 patients, and they received infusion in the ICU. And on second day, randomization was done. So one group of patients received basal insulin degludec, and glulucin was given as bolus for all patients, and another group received glargine U300. Then endpoint we check after 12 days. It was the 12-day glycemic control. Insulin was adjusted daily to maintain fasting blood glucose less than 140 and pre-meal less than 180. What is the standard? This is the standard of care. And you see the glycemic control was almost equal for both the insulins. There is slight good improvement with degludec 100 after day second, third, and after 12 days the graph is almost overlapping. Rapid improvement with this, and this was daily adjustment of insulin. And again here fasting sugar, pre-lunch, pre-dinner, and 3 a.m. sugar. 3 a.m. sugar was measured for all patients, and you can see that fasting sugar was slightly better controlled with degludec U100. Other glucose were similar for both. And here you can see the mean glucose difference was not significant, 157 with degludec and 162 with glargine 300. One thing was better with degludec as a basal insulin. You see the mean percentage of blood glucose readings between 100 to 140. And you know that 100 to 140, as you have already heard from Dr. Parji, that this is the ideal glucose level in ward patients. It was better controlled with degludec. Hypoglycemia were not different. Is a 16% in degludec U100 versus 23% with glargine U300. And severe hypoglycemias, that is less than 54, were very infrequent, 1.6 and 4. It is very less. It's like 1 or 2 episodes in the whole, in the whole population, which 240 patients. So my key messages are all basal insulins are effective for controlling glycemia in hospitalized patients. NPH as a premixed regime must not be used in hospitalized patients. Ultra long acting basal insulins are as effective as glargine U100 for hospital management of hyperglycemia. Insulin degludec U100 and glargine U300 are equally effective. Hypoglycemia are less frequent with these ultra long acting insulins. Degludec and glargine U300 are safe and can be adjusted daily in hospitalized patients. Thank you. Dr. Bijul.
Thank you, sir, for such a lucid presentation and specifically showing the Indian evidence for use of ultra long acting basal insulin. So we have all discussed about the use of insulin in hospital hyperglycemia management. But can oral anti-diabetic drugs be used in hyperglycemia management? So to discuss about the utility of OADs, we have Dr. Harmandeep Kaur ma'am. Ma'am is a senior consultant at Medanta MedCity. Over.
Good evening, everybody. So I'm Dr. Harmandeep. So you are welcome in this CMA. So here we are with the last topic, and I will not take much time. It is about the OADs. So here we don't have specific guidelines. We have some data and some expert opinions on it, and more experts, they are suggesting that we should use these OADs in hospital settings also. All the time we are discussing about insulin and management, so all the guidelines also, they are about the insulin. And insulin is something where you don't have to apply much brain to individualize the treatment. You just see the numbers and you adjust accordingly, although there should be some protocols to follow. But when you are thinking of OADs, here definitely you need to individualize the therapy. So because we don't have specific guidelines, so we will have to make our own consensus. So why there are no guidelines? Because for most of the time we had only metformin, and we were always worried about lactic acidosis. So that was a big worry. So it was never allowed in hospitals in acute illness. The second thing was we had sulfonylureas all the time, and we always knew that they increase the risk for hypoglycemia, and that is also a big worry. So they were also not allowed. Then there came these new drugs. They were DPP-4 inhibitors, and now we have SGLT2 inhibitors. But definitely you take time, you need time to assess their efficacy and their adverse effects when you make some guidelines. And we are hoping, like with all the experts recommending them in patient setting, that in near future we will have some guidelines around that also regarding the OAD part. But definitely that will need a lot of brainstorming, because where will you allow and where will you not allow, because there are some things associated with them. So here I think we are all practitioners here, physicians who are dealing with diabetes all the time. So I think we should have our own consensus also, like what we want to do with these OADs. So as we all know, most of the guidelines till now, they are suggesting that all the persons should be on insulin and ICU, whether it is infusions or sub-Q basal bolus. And we are discussing whether we should use OADs as well. So we will start with the first case. So here this case came actually online, and everybody was to opine around about it, like whether what do you want to do with this patient. So you see, this is a 72-year-old female, 5 years of diabetes. She was well controlled on metformin. Her HbA1c on admission was 7.7, I think. So she is having fever. She has some lung patch. She has pneumonia, community acquired pneumonia. She was put on IV antibiotics. She had fever. So her oxygen saturation was 88%. She was hemodynamically stable, but her oral intake was poor. So otherwise, if we see her reports, her KFT, LFT, everything was normal. She was admitted in the hospital. So as everybody mentioned, like what do we want to do? So first of all, we want to see, like, first is the medication. You always ask what patient was taking. She was on metformin. She was taking 500 milligrams twice a day. Then you want to know, like, how was her glycemic control when she was better, she was at home. So HbA1c came around 7.7. So now is the question, like, do you want to use OAD, or you want to stop metformin, or you want to continue metformin? So metformin is a kind of very controversial thing. Like, always we are afraid of lactic acidosis. And so what would be your opinion? So options are to continue or discontinue, obviously. So these two things. So I think you can raise your hand who are with metformin. Yeah, so who want to discontinue? Okay, so not many people are raising their hands. Okay, so what we all the time were doing was we wanted to discontinue metformin, right? So here the surprising thing was that 60% people, the most of them like intensivist as well actually, so they wanted to continue metformin. So 40% people were in the favor of discontinuing it. So what were the factors actually? So why people wanted to continue metformin? So you all know, so metformin, when you discontinue, every diabetologist who practices actually diabetes know that in many people, whenever we stop metformin, glycemic control becomes worse. It is very difficult to control actually in many patients. So some people come with GI upset, with diarrhea or something, you have to stop metformin and then you struggle. You put all the OADs, the control will never be same. And many patients prefer to go back to metformin whatever their GI upset is. So people think like metformin is one thing which is working at the pathophysiology, it is reducing the resistance, and when you stop it, your glycemic control worsens. The second, so insulin, for most of the patients, that is a burden. Like whenever we stop OADs and we counsel patient like you have to be put on insulin, it takes hours actually for educators, for our DNB residents, and for us also, like convincing patient that for some time you have to be on insulin. After that we will restart your OAD, but that takes a lot of time and it is a burden for hospital care staff as well. All the time they are struggling with insulin checking and just like making it feasible that you give insulin according to the meal. So what evidence we have? So we have used metformin for decades now, and there has been good evidence that the incidence of lactic acidosis is not that high. So we have a big Cochrane database. So there are like million patient years studied with metformin in all the situations, in you can say altered renal function, in altered pulmonary function, in cardiac failure as well. According to that, the chances of having lactic acidosis when you continue metformin or discontinue metformin, they're almost similar. As you can see, with metformin it is 4.3, and with when you discontinue it is 5.4. So the chances of lactic acidosis are comparable actually. The lactic acidosis which we see basically is thought to be because of the underlying disease process as such, not with the medicine. So this is one big thing with lot of data. There is one published data also about the US hospitals. Actually, although these OADs, they are not advisable, but they are being used in all the hospitals we know all the time. In US also they saw like 30% patients they remained on OADs actually is in all the peripheral hospitals, and they got actually good data from there that there was no increased chances of lactic acidosis. So then now we have, then all the cutoffs were also reduced, like you can use metformin in CKD3 state as well. Then in CHF also the things became more lenient, like you can use metformin. So regarding the option 2 actually, so the people who wanted to discontinue metformin, what was their suggestion? They were like still there are no recommendations, we don't have any compiled data like till what stage we can use metformin. The next was like patient is old, she's 70 years plus, actually she's diabetic, she has pneumonia, right? So she can worsen anytime. So she can go into sepsis, she can go into AKI, she can land up in lactic acidosis. So they didn't want to give it. So, and the important part, like her oral intake is poor. So the people who wanted to discontinue metformin, they didn't want to actually irritate the GI, they didn't want to increase gastritis and all. So the people who wanted to give metformin, they told like, person's intake is already poor. If you start on insulin, there are higher chances of hypoglycemia if you inject wrong doses, or maybe patient doesn't eat or vomit or something. So, and because we all know in all the infections there are chances of stress hyperglycemia, obviously you will have to start insulin somewhere, whether you continue or discontinue. Okay, so this is our own hospital data. So regarding same the problem of lactic acidosis, because here we do continue metformin till the day of surgery. So we wanted to have some own data, although there are published trials, long list of trials, who used metformin before surgery with good results. So here also we had similar data. We checked the lactate levels post surgery. So there was no significant difference between people who continued, who discontinued, and who were the controls, like people without diabetes. Now the next case. So this is a 73-year male. He's diabetic for 6 years, and he has undergone knee replacement. Again, all the parameters good. Patient is stable. He's eating. All organs, they are fine. So it is post-op day 2, you are called. You had given the clearance for the surgery, and you told them you can continue metformin. So again, so patient was on metformin 1.5 grams daily. So these are his readings, like fasting 150, 162, and pre-prandial readings. They're going up to 180, and the surgeon wants a better glycemic control because patient is old, diabetic, knee replacement. He doesn't want any infection. So what would be the next thing? What should we do, right? So here we are. One option is to go for basal bolus therapy, again, which is recommended actually. Other than that, what else it can be? So do you want to give sulfonylurea? Of course no, because he's an old patient, post surgery, glycemic control was good before surgery, and we are worried like sulfonylurea can cause hypoglycemia. So obviously I don't think anybody would like to start it. So next, another group is there, TZDs, although they are not any favorite now, and the important point here is that they take long time to show their effect, so they are not good for inpatient setting. So DPP-4 inhibitors, so do you like to start it? So this is one drug which doesn't have, this is kind of a good drug which doesn't have many side effects, almost no, I would say. Soft, they don't cause hypoglycemia, particularly when they are combined with metformin or used alone. And for mild hyperglycemia like this, they are like quite suitable drugs. So what about SGLT2 inhibitors? Do you want to start it? So maybe some people would, but I think patient is post-surgery, old, he will be undergoing physiotherapy, he will have to stand, he will have to do some exercise, walk. We don't want any like dizziness, and we don't want him to go to toilet all the time. So he will be in a fix. So do we have some data regarding DPP-4 inhibitors? Yes, we do have. There are some, initially there were pilot trials, and then there was this good trial, CETA hospital. So sitagliptin was used in medicine and surgical wards with good results actually. So, so two groups were compared, one on basal bolus as usual, and the second one was on sitagliptin plus basal actually, and correction doses were used whenever required. So if you see the glycemic control, it is, if you see the mean glucose over the days post surgery, so during the admission, they were almost equivalent. And if you go for the daily variability, so it is same whether it was basal bolus or it was CETA plus basal insulin with correction doses, of course. So similarly, we have trials with linagliptin as well. So this is the post-surgery group LINA-SURG study. So here also the data was typically similar to sitagliptin. Same thing was used, either basal bolus or linagliptin with basal insulin plus correction doses. So data is similar. Similar trials are there with saxagliptin as well. And the results are showing there are no adverse effects that we all know, and the glycemic control is almost similar. So there are some little bit, like we all know that pancreatitis, risk of pancreatitis, that is there, we should not use. And there is saxagliptin story, which is a sad story, that there is some risk of heart failure, maybe, we are not sure, but it is not recommended. So what about SGLT2 inhibitors? We will not take long because there is lot of supportive data. Everything is coming good about SGLT2 inhibitors, but whether they can be used in hospital setting, we are not sure right now. So we need more data to be sure that there are no adverse events. So what we have is, so one trial we have that was done during COVID-19 actually. So the first one which appeared in Diabetes Care. So this was a positive trial. Actually, the people who were on SGLT2 inhibitors, they did well. Actually, there were lower chances of decay in these patients. But on the same side, DARE-19, where they used actually SGLT2 inhibitors in hospital, the patients who were admitted with respiratory failure with COVID-19. So the data was not good. They had many of the patients, they had decay, but data was extrapolated actually because there were very few patients. So not a good study otherwise. And what we have is heart failure. We all know there is a lot of data coming out. The trials on OPD settings were there, but in hospital there is IMPULSE trial, which has shown like there is no excessive adverse events noted as compared to placebo. So the patients, the heart failure patients, they did better actually. So their the events, they were lesser, their mortality was lesser, hospital stay was lesser, and the post-hospital recurrent admissions with heart failure were less. Again, this study was just in 560 patients or so. So this is one study going out in our hospital also. We are also watching like whether it can be used in hospital setting or not. This is in the post cardiac surgery patients basically. So we have some data. First 15 days data is there with us with most of the patients, and there are no decays, at least we have not detected any. So take home messages: in mild to moderate hyperglycemia, so that is the condition. So if patient has severe hyperglycemia, obviously insulin is the solution, but in mild to moderate cases we can think of OADs. DPP4 inhibitors, they are safe to use. We have good studies to and then metformin. Metformin, if there is no major organ dysfunction, obviously we can consider it. Sulfonylureas, definitely everybody is saying all the guidelines, it should be avoided. And SGLT2 inhibitors, more data is coming. We should wait a bit, and maybe we have some indications for in-hospital setting as well. Thank you.
Thank you, ma'am, for clearly showing that we cannot just write off OADs in hospital setting. So now I invite our panelists for the panel discussion. We have Dr. Parjeet Kaur, Dr. Harmandeep Kaur, and Dr. Shafi Kuche with us as panelists. So I would request the audience also to actively participate. Anyone who has the query can raise their hand. We will take the queries simultaneously. So I would start off with Dr. Shafi. Sir, you presented Indian evidence and particularly your data that second generation basal insulin are also safe in hospital setting. So, but considering their long half-lives and they take a longer time to achieve steady state, so how frequently dose titration should be done if we are using second generation basal insulin in inpatient setting?
Okay, when second generation this ultra long acting basal insulins came into market, one apprehension was that in hospitalized patients, because they have a long duration of action, they remain there for more than 48 hours, so daily adjustment would not be better. It may be like stacking up insulin and later on they may cause hypoglycemia. But all these randomized trials, there was daily adjustment of insulin. And in our study also we did daily adjustment to insulin. That's a theoretical concern that practically actually doesn't exist. It is safe to adjust basal insulin, ultra long acting basal insulin daily, and it gives like smooth control. There is no stacking up insulin. There is no hypoglycemias after second or third day. So there it is safe and it is the standard of care everywhere.
So clearly a myth is busted that second generation basal insulin we cannot do daily dose titration. So my next question is to Dr. Bajit ma'am. Ma'am, according to you, how to manage steroid-induced hyperglycemia? Because in the COVID era, we have seen that many patients are on steroid, and steroid-induced hyperglycemia, how to effectively manage it?
Yes, I think it's a very relevant question which I did not cover in that talk. So we do see steroid-induced oncology patients, pulmonary medicine patient, and COVID-19. We had a huge experience. So when the patient is on steroid, and three things we need to know. First of all, what kind of steroid the patient is receiving. Secondly, what is the route, whether the patient is being given IV or oral steroid. And thirdly, what are the timing, how frequently the steroid is being given. So for example, one patient is being given just oral steroid, prednisolone in the morning time versus a patient who is receiving IV methylprednisolone twice daily or thrice daily, which our COVID patients also received, or a dexamethasone twice, thrice, or a hydrocortisone. So if the patient is receiving just one single dose in the morning, so we can then somehow anticipate the blood glucose control, because the one shot in the morning of a steroid will mainly cause a rise in the evening blood glucose levels. So in these patients, what we do is we kind of give a extra evening dose, 4 p.m. dose of insulin, which will take care of the before dinner rise in the blood sugars. However, if the patient is round the clock insulin, we have to then give accordingly the step up the boluses as well as the basal. But whereas the patient is on just one daily dose of steroid being given in the morning, sometimes these patients will not even require basal much. With boluses will take care of the blood glucose control. So definitely we can still follow the same protocol, same chart, but these patients we need to keep in mind how the blood glucose is being affected.
Thank you, ma'am, for sharing your valuable experience. Now I move to Dr. Harmandeep, ma'am. Ma'am, you showed that metformin can be safely used till the night before surgery. So what about the usage of other OADs in a perioperative period in a patient who is admitted for surgery?
Perioperative. So generally the protocol which we follow is that if patients they are uncontrolled, definitely they are sent in for clearance first. So if patients they have uncontrolled blood sugars, we will have to see what we can do. It may be some escalation in dose of OHAs, or if the sugars are very high, we may like to start on insulin and control the blood sugars and then go ahead with the surgery. So people who are well controlled on OADs actually, so generally after we had our own study and we have data to support us, so generally we continue with OADs till the night before surgery, and after surgery it depends like what kind of surgery patient has undergone, but mostly it is that we start with basal bolus therapy. So that is the protocol actually. So then at the time of discharge, we can think of like whether we want, if patient is stable, everything is fine, he's eating, wound is fine, then we can restart with OADs depending upon the pre-admission status actually. So if glycemic control was already good, we can restart his previous regime only. And if there is some concern, if we want to modify, then accordingly we do at the time of discharge. So that is how we do.
Thank you, ma'am. So now I move to Dr. Shafi, sir. Sir, if a patient is already on first generation basal insulin, and if we decide to start him on second generation basal insulin during inpatient setting, so what dose adjustments are to be made?
Yeah, usually all basal insulins unit wise, there is no much difference. You can, if you want to switch over to second generation, you can go directly to the same dose. Dosage wise, there is no change. Then you can follow and you can measure glucose and then you make adjustments. But there is usually no, dose adjustments if you switch from one basal to another basal.
So we
But,
can.
but if you are giving NPH, if you are giving NPH 2 doses, there you have to make adjustments because you are giving long acting as a 1 dose. There, otherwise, for glargine to this degludec 100 or glargine 300, there is no dose adjustment. You can give directly same dose.
Okay, sir. So, Dr. Parjeet, ma'am, you clearly showed that basal bolus regime is the cornerstone of glycemia management in non-critical setting. So, what do you think about the correctional or supplemental doses of insulin? What is their utility?
Yes, I think it's very important when you're deciding the dosages that you also decide the correction dose as I had shown in that case, because correction is important. Many times patients have variable food intake. So one time the patient is eating less and you had written a certain dose anticipating, okay, this much blood sugar will come. But however, the patient has eaten less, the blood sugar might fall to just 70, 80. That is the point of time actually it's not that you completely do not give insulin or you give the same dose. There the role of correction is that okay, you minus the certain amount from the pre-decided dose and give that. Similarly, if the patient has got a very high blood sugar, maybe because in between some steroid was given, or if the patient appetite has suddenly improved, so you give that correction, add a certain on the pre-decided dose so that the next value you get is a better value. So there's a huge role of a correction dose which should be there in the protocol along with the pre-decided boluses.
Thank you, ma'am. Next question is to Dr. Harmandeep, ma'am. Ma'am, is there any utility of adding OADs to a patient who is already on multiple daily injections of insulin in inpatient setting?
In inpatient setting, that actually, if we ask about the data, so there are some studies to show definitely like in type 2 diabetes we continue with metformin. At least that was like from olden days we are doing that metformin is continued because that reduces resistance. So in inpatient setting, actually if glycemic control is good with your basal bolus therapy, generally they don't require OADs, but we do see cases where glycemic control is very difficult. Actually, they are the persons who are very resistant. And if you think patient is stable, hemodynamically stable, or no organ dysfunction as such, in such a case, we do see utility of metformin. Like after some time, you can start with metformin. And secondly, there are data to show that sometimes DPP-4 inhibitors also give a good control actually in people where there is a lot of variability or maybe more of prandial spike. So even DPP-4 inhibitors, they do help actually in better glycemic control. But definitely we are using it where we become little helpless. Yeah, okay.
Thank you, ma'am. The last question is to Dr. Shafi, sir. So one important advantage with second generation basal insulin is the flexibility in timing of administration. So how do you see it as an advantage in inpatient setting?
Yeah, this is very important because for NPH there is no advantage. You can't give, NPH if you can't change the timing much. For second generation long acting, for example, for degludec U100 or glargine U300, if because in ward your patient may go for ultrasound and he needs fasting for few hours and your dose is scheduled, for example, in the morning 10 a.m. And you can miss insulin at that time. You can give same dose of insulin if he comes, to the ward at 1 p.m. So you can give that basal at that time. There is no change. You can give it any time of the day. It doesn't change the glycemia pattern. But this flexibility is not with NPH or Detimir or for glargine U100. Their timing, if you change timing, if the change is significant, it will alter your glycemia pattern. So there is this advantage with these long-acting second-generation basal insulins.
So definitely it is an important point. So if there are no further queries from the audience, there is one query.
Yeah.
Yes, sir.
It has been my experience that post-op and patients on their second or third day tend to have much lower glucose values as when they would normally be taking whatever medications they were. And this tendency, for some strange reason, seems to continue for about a week or so after discharge also. Have you also had the same experience?
Yeah, I think it all depends upon the diet. And that's how we tell patient also, okay, look at your diet, how well controlled the blood sugar is. So I think it depends upon their appetite and how it's gone down. And initial few days, 1 day post-op, they're on liquid diet as well. Gradually their appetite is gained. I think that's the...
Yeah, so we have seen this in hospitalized patients because the diet becomes, fixed, and particularly in our hospital where outside food is not allowed, we see sometimes patients, on same regimen, they get good control. Then when we ask them why your glucose is now controlled, they say, यहाँ तो कुछ देते ही नहीं है खाने के लिए. So maybe this is the reason.
And it also depends upon the kind of the disease they were having before. So suppose if you have a patient with the kidney disease, or if your patient is already lean and thin, so it varies. So the individualization of the therapy has to be done, and we have to keep the thing keep open. Adding the oral anti-diabetic drug and new therapy, we should be the case based, I think.
Yeah.
Dr. Shakti, just a quick
Yeah.
question. Yeah. Coming to the question of conversion from the first generation to the second generation, we don't have much experience with the Detimir.
Yeah, we don't do it usually.
But if I recall, Detimir at low dose, 0.3 units per kg, it acts as an intermediate acting. If we use a higher
definitely.
dose, it acts as a
Yeah.
single dose. So how do we change from the Detimir to second generation?
We usually do not change the dose. Yeah, this is a fact. This is also seen sometimes with glargine U100, because if you give less dose, less than 20 units, it doesn't act, for 24 hours. Sometimes it act for 18 hours. The duration is for 18 hours. But I don't know if there is difference. I have changed in a few cases. I remember from Detimir to this glargine U300, but I didn't make any change in the dose. I don't know there is any conversion. In fact,
Yeah, no, even I've not. I think better to give on the, if the patient is in the hospital, lower dose, and then you can step up gradually depending upon the sugars.
So if there are no further queries, I thank all the panelists for their valuable input.
thank you very much.
Thank you all. Thank you so much.
So now I invite Dr. Sunil Mishra sir for his final comments and vote of thanks.
Thank you, Dr. Rujul. Thank you, Dr. Parjeet, Harman, and Dr. Shafi. So I think this was a first in-person meeting, and this has gone very well. That's what I can feel, and I cannot expect a better meeting than this. Definitely, we will try to make it better next time through the inputs we get from you, and we try to tell what we are doing. We have not tried to tell what more written in the textbook, only in the science and randomized control trial. So whatever we've been doing for last 10 years, 12 years for in-hospital diabetes management, we try to explain, and we try to share that knowledge with you. And we are always free to discuss with any type of the case. Also, as I told you, that we have a diabetes educator program where you can send your diabetes educator for training with us. We will definitely give them a hand-on training for a better diabetes education, and then you can utilize that services in your particular hospital. We have published protocol you can download from internet, and then you can utilize for your patient care. Anytime, we are always there to reach out for any sort of the discussion, your case-based, individualized, or you want to set up your own in-hospital diabetes care management. So thank you very much for your participation. Any meeting cannot be successful without wonderful participation from such a large audience. I also thank my industry partners who have helped us for successful conduction of this meeting. Novo Nordisk has given an unrestricted grant for successful conduction of this meeting, and a very short notice. Also, this Sun Pharma Aviate division has given us a good support without giving them a lot of time. Sun Pharma, Avian division, and Intas Pharma were another support, and these are all four companies who have been who supported us for this particular meeting, and I thank them all and thank from all of my team. Thank you very much, and look forward to see you again soon.